Sublingual immunotherapy for allergic rhinitis SLIT. In 1986, the use of allergen specific immunotherapy SIT administered by the sublingual route was described for the first time. Until then, the only route of administration for SIT remained subcutaneously SCIT, which was repeatedly demonstrated to be effective in respiratory allergy. Nonetheless, the subcutaneous immunotherapy some risk of severe or even fatal adverse effects still remains. The risk can be partly attributed to technical or human errors and can therefore be avoided. However, a large fraction of the severe adverse events reported remain unpredictable even if all precautions are taken. Based on this, alternative routes of administration were repeatedly approached. Among them, sublingual immunotherapy appeared as a promising route despite initial skepticism owing to the low doses used and the poor design of the earlier studies. Nowadays, sublingual immunotherapy is officially accepted in international documents as a viable alternative to subcutaneous immunotherapy for both adults and children. In addition, thanks to the good safety profile, the use of sublingual immunotherapy has also recently been proposed in non respiratory allergy, and these include atopic dermatitis and food allergy. To date, the principal indication for sublingual immunotherapy remains allergic rhinoconjunctivitis, and most of the clinical data derived from trials conducted in patients with that disease. More than 60 randomized double-blind placebo-controlled trials have been published so far, two-thirds of them in dust mites and grass allergy. Nonetheless, based on common sense and transferring our knowledge about subcutaneous immunotherapy to sublingual immunotherapy, it is recommended to not administer sublingual immunotherapy to patients with severe or uncontrolled asthma. Also, it is recommended that the first dose of sublingual immunotherapy is administered under medical supervision. Below 5 years of age, it is generally considered a relative contraindication to subcutaneous immunotherapy owing to safety concerns. A controlled dose finding study involving 48 grass pollen allergic patients outside pollen season was done. These patients received sublingual immunotherapy for 28 days at progressively increasing doses up to 200 microgram allergens, that is approximately 40 times the dose given subcutaneously. The incidence of side effects was 74%, all of mild or moderate intensity, the most frequent being irritation of the throat and oral itching. An updosing phase, as is usually carried out with subcutaneous immunotherapy, seems to be unnecessary with sublingual immunotherapy, and the treatment course can be started immediately with the maintenance dose. Effects on the natural history of respiratory allergy. Subcutaneous immunotherapy is recommended as part of treatment for allergic rhinitis as an adjunct to pharmacological treatment plan in order to reduce symptoms and the need for rescue medications. This is named the immediate or early effect. Nonetheless, it is well known that rhinitis represents an independent risk factor for the subsequent development of asthma, and none of the available drugs are capable of modifying this progression. On the other hand, sublingual immunotherapy acts as a biological response modifier and therefore induces profound changes in the immune response to allergens, meaning that it can affect the natural history of allergy in the long term. Another important aspect concerning the effects of on the natural history of respiratory allergy is the long lasting effect after discontinuation. This effect has been seen in several sublingual immunotherapeutic studies in adults and in children. And according to literature, the beneficial effects are maintained for 2 to 6 years after discontinuation of sublingual immunotherapy. Now, the protocol for sublingual administration is based on a 1 to 5 dilutions. The drops are administered daily. Dose is slowly increased once a week from 1 drop per day up to 5 drops per day over a 5-week period. When a bottle is finished, a new bottle, 5 times more concentrated, is mixed. Escalation continues without the need to retest the patient. And when the maintenance dose is attained, treatment will continue to complete 3 to 5 years. The same as subcutaneous immunotherapy. Drops are held under the tongue for 20 to 30 seconds and then swallowed. And with this protocol, a serious adverse reaction has never been encountered despite many hundreds of patients being treated. So we have a new immunotherapeutic model to address patients suffering from allergic rhinoconjunctivitis. Sublingual immunotherapy.